Morning, India. I am Dr. Nana, your host for the next 3 days.
Good morning. I am Giridhar Gopal, your co-host for the next 3 days, and for this wonderful conference, the Global Summit on Medical Lasers and Regenerative Medicine. Without any further delay, I'll just request Dr. Nayana to introduce the chairman of the organizing committee of the GSML 2016, Dr. Srinivas Murthy.
I would like to invite Dr. Srinivas Murthy, Chairman of Organizing Committee, to address all of us with his dream project of GSML 2016.
Thank you. My name is Dr. Srinivas Murthy. I am a graduate from Bangalore Medical College from 1978 batch. After that, I did my post-graduation in preventive care and nutrition. I was a lecturer in a medical college for a brief period. And afterwards, I worked in the central government United Nations Development Program for about 17 long years, worked in abroad at various capacities. In the course of my 17 years, more than my clinical pharmaceutical practice, nutritional practice became perfect. From 1999 onwards in India, I was a practitioner of preventive healthcare and nutrition. I was covering the chronic, degenerative, painful conditions only by using the nutrition and then preventive care. During that period, the success rate used to be somewhere around 40 to 45% only. It is my luck that I got accidentally introduced to the therapeutic lasers in the year 2010. Perfectly or imperfectly, we were practicing, and I found there is a tremendous improvement in the clinical efficiency. It shot up from 45%, 60%, 70%, even up to 85%. I opened up my mind and started exploring the therapeutic lasers in the world, how it is going on. In India, it was significantly irrelevant at that time. Nothing was there in 2010 except a couple of clinics. Nobody was knowing what exactly the therapeutic lasers are. Not even the name they were knowing. They were used to call cold lasers. I attended some of the international conferences, including our last Washington World Summit. I learnt a lot. I met a lot of eminent experts in the field of therapeutic lasers. In my practice, I came to know after treating around 7,000 cases using therapeutic lasers and nutrition, I found the correction of metabolic disorders and inclusion of the nutrition along with the preventive care give more results than with the therapeutic lasers alone. That is why we framed the present conference as the Global Summit on Medical Lasers and Regenerative Medicine. Regenerative medicine part, some of our experts are going to speak in the coming hours. See, in this way, I just gathered my strength, used the friend circles to whomever I met in the Washington Summit. I used their support, and that is how this conference has come up. What we want in India, India is a very big country. Approximately we have got around 200 million cases of chronic degenerative painful conditions. And it is well known from the statistics from United States of America also that more than 95% of the cases can be handled by non-surgical means. But in India, the prevailing non-surgical means like analgesics or epidural injections or any of the methods that we use in the physiotherapy, they are not being effective at all. Patients are repeated and repeated. So the only viable method that we found, or rather I found in my clinic after treating nearly 7,000 cases in the last 6 years, is the effective combined usage of therapeutic lasers along with the nutrition covering the metabolic disorders and preventive cares is giving wonderful results. This aspect, I discussed with all the eminent persons all over the world long back, around 11 months back, and I wanted to have in this country one conference at any cost. That is being supported by staff members and some of my colleagues. Today we are here in front of you, the eminent experts in the field of therapeutic lasers. What my intention in this country, the prevailing situation, if you see that, most of the doctors are not knowing the proper way of dealing with the chronic degenerative painful conditions. They have no idea about the energy dysregulations at the mitochondrial levels. Still, they are framed up their mind the methods of acute management of any cases. The present patch of case of practice is not going to help in the chronic degenerative conditions. It requires a lot of patience, perseverance, and follow-up of the patients with the same practice of the nutrition, lifestyle changes, preventive care. So this is what we want to inculcate throughout the country. To effectively implement our plans, we have made very good homework. We know very well that we have to implement the result-oriented treatment, evidence-based practice, and result-oriented studies. For this, we have designed the softwares, even online universities, and many other things which we can manage very effectively with a centralized management system. Even some of the universities in India, they have come forward to take up our project and to effectively implement, because they want to start courses on LLLT to our doctors. We know very well in India it is very difficult to get the doctors to any conference or seminar. So for that purpose, we have designed a software to effectively train them at their point of action. And moreover, in India there is no governmental policies or even any departmental approvals for this. So the last 1 year, we effectively, along with my team members, to implement, and we gave a lot of presentations at the Director of Health Services, even to the ministers. Most of them are happy, and they have declared 10 centers in the Karnataka state government hospitals to start. After the conference, very effectively we are going to implement it. Next is that there is an acute shortage of doctors in this country, practicing doctors. It is simply not possible if we rely on the MDs, MS and MBBS graduates. So for that, in our association, we are seeking the support and participation of even Ayurvedic physicians, even homeopaths, naturopaths, even mainly the physiotherapists. In effective management, I found that physiotherapists can play a vital role. So hence I am banking on them in the coming implementation efforts. More than that, another important thing, we can avoid the disparities in the medical practice that we are facing, Ayurvedic, homeopathic and all. We can bring them on a common benchmark and we can implement it. This I have discussed with the ministerial level also, Ayush department also, they all have agreed for that. Now what I request the eminent doctors and the experts who have assembled here to support us in this cause, and not only in the course of education, implementation and research also. So thank you very much. Welcome all to GSML 2016. Thank you.
Thank you, Dr. Murthy, for this very sharp and crisp introduction. I would now like to introduce our next speaker for the day, Dr. Vijayalakshmi. Vijayalakshmi is a postgraduate and a doctorate in biochemistry and a postdoctoral in molecular and cell biology. She specializes in tissue and cell regeneration. Currently, she heads the Stem Cell Therapy Division at the National Institute of Nutrition, which comes under the aegis of the Indian Council of Medical Research. May I now request Dr. Vijayalakshmi to come in and start her presentation.
All, I would like to take this opportunity to profusely thank the chairman of this organizing committee, Dr. Srinivas Murthy, who has actually played a very key role in bringing a very good crosstalk between the laser therapeutic approach with the regeneration, especially the tissue regeneration. I was really very happy to know that there's a lot of therapeutic regeneration and nutrition combination have actually playing a very critical role in the management of health. So for today's talk, I was asked to speak on what is going to be the implications and what are the new features that National Institute of Nutrition, which is one of the premier institute of Indian Council of Medical Research, is taking it up. Our area is on several domains, but the prominent domain which is of national priority is on the effect of the metabolic syndrome, that is the obesity as well as the chronic diseases which Dr. Murthy was talking to us. So we work on various programs. We work on effect of nutrients and fetal programming on the maternal health. We are also trying to look at the effect of inflammation, which is a very important predisposing factor in obesity and other chronic conditions. We are trying to look at the beta health because diabetes is a very important epidemic, and we are trying to see how newer approaches can be implemented in the regeneration process. And we are also currently interacting with several hospitals with the support of Department of Biotechnology to look for the transplantation programs. So as you see that the global projections of diabetic epidemic is from 2003 to 2025 is phenomenal. As you see in the world, there is a 72% increase, and among the 72% increase, it is very sad to note that India is contributing for 79.4% of the increase in the episode of diabetes in the world. So it has become a really health issue of major concern, and that is why there is a priority research in the field of metabolic syndromes and diabetes and obesity. Co-precipitating with the obesity is, diabetes is the obesity in the childhood obesity, the adolescence obesity, the adult obesity is phenomenal. And also we find that because of the lifestyle changes, because of more and more less physical activity, with more intake of the saturated food and with various other non-conventional foods, there is an increase in the obesity episodes, which is playing a major predisposing factor in development of diabetes. So this is what the chart shows. There is a sequential increase in the obesity rise. And what are the important conditions? So when we say, I know this group is very well conversant, but nevertheless, for those who have not, students and other graduates, I would like to say that there are almost 4 types of diabetes. Type 1 diabetes, which is very much decided in the young or in the adolescence age. Type 2 diabetes, which is onset in the later part because of the lifestyle changes, because of the environmental, the genetic and so many factors. We also have what is called as the MODY, that is the maturity onset diabetes. Then we have the latent autoimmune diabetes, and now very recently in most of the pregnant women what we find as the gestational diabetes. So these are the important classes of diabetes, but among them the gestational diabetes, the type 2 diabetes, and as I said 78.4% of the Indians are being recorded for diabetes, so it is something to really worry about and look into very seriously. So what is the work what we are trying to do? So the conventional therapy like the insulin shots, taking the metformin, taking the rosiglitazone, all of them are definitely helping in the management of diabetes. But however, the applications are very limited, and even on the long term it is going to have some of the side effects. Like Dr. Murthy Garu was narrating just before me, that nutrient interventions which are known to be a potent antioxidants also help to play an important role in minimizing or in almost normalizing the levels of some of the inflammatory markers. So in our group we try to understand the question, like once the beta cells of the pancreas, they are exhausted, that is what happens in a diabetes. It is unable to secrete more amount of insulin. So what are we supposed to do? Can we not coax it with more growth factors? Can't we not give them equivalent to a nutrients so that we can start sort of activating the resident progenitor stem cells? So that is how the concept of stem cells have come into the picture. And before actually the stem cell transplantation and the approach of stem cells for type 1 diabetes was understood, Dr. Shapiro from Canada published a paper in 2000 where he demonstrated that taking the pancreatic, that is the islet cells from the cadaver, he could actually transplant on type 1 diabetic patients and show 40 to 50% recovery in their insulin levels. So that was a wonderful, and it was an eye-opener for all the diabetologists as well as for the research scientists. But what happened? But as you know that all the differentiated cells, they have a half-life only of few days. So in the same way, the beta cells of the pancreas, which are very essential for secreting insulin, unlike the alpha cells which are for glucagon, so the beta cells have only 90 days turnover in the body. So after 90 days, a new beta cells are being secreted, synthesized, and they start taking over the function of the new insulin secretory function. So because of this differentiated cells, so the application of the cell transplantation using the cadaver patients became a restriction, and then there is an eye-opener for the stem cells. And I'm not going to go into the details about the stem cells because I'm sure that each one of us know there's 3 different classes of stem cells: the embryonic stem cells, the fetal stem cells, and adult stem cells. And we know that the Department of Biotechnology and ICMR, they have put lot of ethical concerns using the embryonic stem cells, and hence more and more projection is given on the adult stem cells, especially the mesenchymal stem cells. However, we are using the embryonic stem cells only for the research purpose in our lab, but I will not go into the details of that. But what we are trying to do is, we are trying to take the mesenchymal stem cells from the placenta, from the umbilical cord, from the peripheral blood. We are isolating the mesenchymal cells and we are cryopreserving them in our labs so that we can use it for the research purpose and also for looking at the beta cells and other microvascular complications. Now, what is so important about the stem cells? Any stem cell, when you take them from the, from the source of their target organ and put them in a Petri plate, you will find that they work like a magic cell. That means you can actually give them the right protocols, right factors, and actually bring them to the cell of your interest. For example, you can take a skin cell and you can transdifferentiate into a muscle cell. You can take a skin cell, you can transdifferentiate them into a liver cell. So in the same approach, we have taken the pancreatic progenitors, we have taken the mesenchymal cells, and we have tried to convert them into insulin secreting cells, and we have been able to be very successful in both in the model system, in the small model system, and with the help of Government of Biotechnology, we are able to even go up to the level of the monkeys, and now the first phase of trial is already ongoing with the human patients. So basically, the model systems have really helped us. It has been an eye-opener for us to understand how important the stem cells can be, manipulated, regulated in culture, ex vivo, and then transplanted in vivo in order to regenerate the damaged cells. So this is one of the important area, and I regularly attend lot of islet cell biology meetings and regenerative meetings, and we find that there are more and more promises which have been implicating for the stem cell applications. So what we have tried to do is, we published a paper in 2011 where we thought we could actually take the damaged pancreatic cells. For example, a patient comes to the clinic with a pancreatic damage in the beta cells damage. So the question that arose in us is, the question that we asked is, can we not repopulate the pancreas with the healthy factors? So one of the important healthy factor was the vitamin B6 and retinoic acid. So studies have demonstrated very clearly that vitamin B6 has got a very important effect, especially in type 1 diabetes, because it is able to negate, it is able to ameliorate the GAD65 autoantibodies which are actually found within the cell. So what we have done is, we have isolated the islet cells, and then we have sort of followed the protocol for isolating the progenitors, and then these progenitor cells, they have been grown under the influence of vitamin B6, and in vitamin B6 there are 3 important coenzymes. And I'm sure all of you know that these vitamins are important moieties, and any of these vitamins are important coenzymes. They are associated with more than 100 to 200 coenzymatic reactions, and these cells, vitamin B6, demonstrated a very genomic response. So the genomic response, what I mean is, apart from the coenzymatic function, it is able to intercalate in the nucleus and able to proliferate the cells. So we found that the progenitors in mice, so we induced STZ diabetic model system, and we induced a damage. We isolated the pancreatic progenitors, we gave them an exogenous vitamin B6, and we gave them retinoic acid, and we were able to 30 to 40%, we were able to correct the damage, the apoptotic cells, and then we were able to get the new islets. These are the new islets. What you find, the orange color, I'm sorry. I'm sorry that I didn't realize that you are not able to see the cells. So we were able to get the new islets, and what we have done is, we have tried to secrete more and more insulin by introducing more amount of the micronutrients. So for this, what we have done, we have gone to the embryonic origin of cells. So during the embryonic development, once an egg is formed, fertilized, it converts into 2 cells, then it converts into 4 cells, then blastula, gastrula. So we have followed the same pattern of the developmental transcriptional pathway, and we have demonstrated the formation of this lineage commitment. So in that way, we show that we have been able to show the successful transplantation of the insulin secreting cells, which are formed outside the test tube. We have then converted them, we have put them into the subrenal kidney capsules, and we could able to regenerate to 40 to 50%, and this was really an eye-opener. So following this, we have taken up our other experiments using the type 2 diabetic model system. So in the type 2 diabetic model system, NIN is the only, we are actually applied for the patents. Along with the Zucker models and other model systems, we are having the obese rat, which are similar to what you find in the human scenario. So these model systems, actually, they put on gain weight under a very fat diet, under a sucrose diet, and they are hyperlipidemia, they are hyperinsulinemia. So because of these features, so what we have shown is they are very close to the human scenario. So taking these model systems, we have tried to understand, see, what is the cause of obesity and what is the cause of inflammation. So when we have studied the cause of inflammation and cause of obesity, we found that similar to what you find in the population, the visceral adiposity is very much hypertrophied. So the visceral adiposity is playing a very, very key factor in these animals. So we wanted to extrapolate whether the visceral adiposity and the stem cells, do they have any crosstalks. So when we found the bone marrow, we have harvested the bone marrow from these animals, and when we try to look at the bone marrow and we try to transdifferentiate them into adipocytes, we found that the bone marrow derived adipocytes, they are also going into a visceral adiposity. Essentially, in postmenopausal women, especially in the postmenopausal women, the visceral adiposity is more contributed by the bone marrow derived adipocytes. So this was a very important finding which we have published in the PLOS, and we've got very good leads from various other target organs similar to the subcutaneous adipose tissue, with respect to the visceral adipose tissue, with respect to the gonadal other adipose tissues. So we have been able to, now we are working out which adipose tissue is more dangerous and how can we manage them with the nutrient intervention. So we have done a microarray analysis, and a microarray analysis very clearly showed that there is a mitochondrial, the stress what we have seen, that is the endoplasmic reticulum stress, and this endoplasmic reticulum stress is playing a major role for the visceral adiposity, and by decreasing the weight of these animals, so we put the animals onto, we are having a very mini treadmill in our institute, so we put these rats, the obese rats, in the treadmill, we showed them the decrease in the weight gain, and after showing the decrease in the weight gain, we found that there is definitely the inflammatory levels, the increase in adipokines, decrease in leptin, PPR gamma, which are the key markers of this, the adipose index, they were all come down. And most important, the insulin resistance has come down with respect to physical activity. So these are all very important findings. What I want to say is, working with type 1 and type 2 diabetic, although we are working with the model systems, we are able to come very closer links which we can actually translate, bring a translational research into the, in the natural occurring in the human subjects. So based on that, we are doing a metabolomics. So now we have recruited patients and we are going to do a metabolomics analysis. And as you all know, nowadays the epigenetics and metabolomics are one of the key areas which can answer the metabolic syndromes, and that is actually $1 million question, that whether it is an epigenetic changes, can we reverse it or can we not reverse it. So based on this, we have published another interesting paper in Cell and Molecular Biology, where we have shown that even under the ultrastructure, the insulin is able to have lot of apoptotic granules. So when you look under the transmission electron microscope, you find that there is lot of, the dense granules which are floating in the insulin cells, especially from the obese patients as well as from the diabetic patients, which we fail to see from the normal individuals. So we have hypothesized with a very complex mechanism, and we say that the inflammation is one of the predisposing factor, and when there is an obesity, obesity is another predisposing factor which can actually bring down or enhance the immune insult to the cells. So mesenchymal stem cells, we are projecting them as one of the important immunomodulators. So very recently, before I came yesterday, one of my postdoc students who is working gave me a very good information, in fact a promising information, that when we are injecting the mesenchymal cells to an obese individual, we are able to reduce the inflammation, the acute inflammation, at least by 30 to 50%. Actually, we have done a statistics on from 15 animals, at least 7 to 8 animals have shown a very positive response, but it is too early for me to comment because we need to look at the histopathology to see if there is a compensatory mechanism what is actually taking place in the tissue level. But nevertheless, we are able to show that the mesenchymal stem cells, they are highly immunomodulatory, and especially the mesenchymal stem cells which we are harvesting from the placenta, from the human umbilical cord, they are able to have a better beneficial effect as compared to the bone marrow or from the adipose tissue derived mesenchymal cells. So we have been able to demonstrate the transplantation. Unfortunately, I am not able to show the pictures. I am not able to show the pictures. It is not detecting. I am so sorry because I got some of the nice transplantation photographs. So we have been able to show the transplantation in the monkeys very successfully, that with a biocompatible device, and each biocompatible device takes around 100 to 150 islet cells, and we have transplanted them in the subcutaneous and in the sub-thigh regions. And now, based on the leads, the ICMR along with DBT, we have started on the pancreatitis patients, and the patients are actually, they have not gone into any any complications, and they have taken the support quite positively with their normoglycemic status. They are still maintaining the normoglycemic status. It is very much in the phase 1 stage. So in addition to this, my group is also looking at the diabetic complications. So diabetes, as we know, is definitely, it's a glucose homeostasis goes haywire. But in addition to that, the microvascular and macrovascular complications are something which we need to worry. Despite taking metformin for 30 years, despite taking any kind of drug, you cannot help the vascular complications. So what we are trying to do is, we are trying to work again with respect to the endothelial cells. Can we not generate the ex vivo, the endothelial cells, and try to introduce the new endothelial cells along with the growth factors and with important micronutrients which are playing a very important antioxidant levels. And we have been already able to show that when we are able to demonstrate a lymphedema case, in one of the lymphedema case in rabbit, when we are introducing the endothelial cells, there is some kind of a regeneration which is actually taking place. And how did we ascertain the regeneration? We have done an in vivo imaging tracking by giving the labeled fluorescent cells, and we have an equipment what is called as the in vivo imaging system. So we have been able to track the cells, and we are able to see the turnover of the new GFP cells. So this is another important lead where we are trying to work at the management of the micro and the macrovascular complications. So these are the advantages, and in addition to that, I will, because I am not able to project the slides, finally I will just say that our other important area is on the fetal programming. Maternal health and child care is a very, very important area, and as you know, in India, 30 to 40% birth is intrauterine growth retardation. That means the mothers are micronutrient deficient. They are either with folic acid deficient or with vitamin B12 deficiency. So because of this deficiency, the epigenetic changes are now getting imprinted in the offspring, and they are getting more predisposed to develop obesity, other diabetic, cardiovascular risks by the time they enter into the adolescent ages. So this is a priority research by Government of India, and we are already working on that direction, and we are having lot of the small scale programs where we are educating the mothers to take adequate nutrition interventions, follow up with the hospital-based studies, and we are also using the embryonic stem cells as a platform in the lab, developing them into a micro-deficient embryonic stem cells, and looking at how can we delineate the signal mechanisms and the crosstalks. So these are all the work that is being done in our institute. So finally, I would like to thank all my collaborators, like Department of Biotechnology. They support us for all the stem cell work. ICMR for giving us lot of infrastructure support. Then, all the collaborators with Manipal Institute of Regenerative Medicine who are here in Bangalore, very supportive to give us the human placental cells. And in addition to that, all my students, postdocs, who have contributed for all the work, and past 20 years we are in this field. Thank you once again for your patient hearing, and I'm extremely sorry that my laptop has not detected, although I put lot of effort to give a good presentation in the form of the data what I wanted to share. Thank you once again.
Any questions from the audience? Dr. Vijayalakshmi would be happy to take up any questions you may have.
Ma'am, with relation to inflammations, have you specifically tested any nutrition as such? I mean, does omega-3 help? Is there any study specifically showing that the inflammation levels can come down with omega-3?
Yes, sir, it has already been done. Omega-3, when fed to these obese rats, the inflammation has drastically come down.
So,
Actually, it is my other colleague is working in that direction. I have not presented that.
thank you very much.
Thank you, ma'am, for a wonderful talk. I'm Dr. Gururaj. I have a few questions. You have probably already know of the PGI paper on use of bone marrow stem cells for reversing insulin dependency. And I would like your comment on that, whether it is a successful approach, because they have done an RCT on that already, and they have shown some good data. The second thing I would like to know is your comment on what kind of inflammatory markers you are looking for when you treat the patient, treat your rats with mesenchymal cells, and what kind of inflammatory cytokines you have a profile for it, and what are the major cytokines which you are looking for?
Yeah, we are looking at both Th1 and Th2, the entire cytokine profile, but we have been able to pinpoint very categorically. In type 1 diabetes, we have IL-18, and in type 2, it is more of the IL-6 and IL-2.
And lastly, the thing about brown fat versus white fat, and what is your comment on that?
Yeah, it's a very interesting question what you have asked. We are trying to now, differentiate the white adipose tissue using the factors to the brown adipose tissue. We are trying in order to see whether we can increase the thermogenesis so that we can decrease the adipose mass. We are on the job now. Pardon me, sir?
On the bone marrow stem cells.
Sir, PGI trials, because most of the trials do come to our institute also for our preclinical trials, it is still very much in the phase 1. But
so they have done a randomized control trial where they have treated patients with their own bone marrow stem cells,
yes,
intraarterial injections in the pancreas, and they have shown that insulin dependency is reduced or even reversed completely.
But it needs to be authenticated with more data, sir, before it is actually accepted. But just adding to your question, the induced IPS technology, I mean, it has been extremely promising because you are able to get several millions of islet cells, using the non-somatic, using the somatic cells. So that is now projected as one of the important area for beta cell regeneration.
Thank you, Dr. Vijayalakshmi, for your wonderful talk. Sincere apologies for not being able to connect your laptop for the projection. Friends, please note that we are on live webcast in 165 countries around the world. Now, I would like to introduce Dr. Pramod Chindar from HCG International Stem Cell Services. He is Head of Orthopedic Oncology. Today he is here to introduce us regenerative orthopedics.
Audible? Yeah. Good morning. I am basically an orthopedic surgeon who, during my journey of orthopedics, of course I didn't see all these things at all in the regular orthopedic training. I think during my course of my training in India and abroad, I came across all this. Can you switch over to the presentation? Yeah, that's fine. So I came across, initially I took my training in National University of Singapore under Professor Fo. Then I went across to Italy in Bologna. I was there as an orthopedic oncology. So I am currently pursuing my orthopedic oncology in HCG hospital. It's the largest cancer care hospital in India. I came across this regenerative orthopedics thanks to Gururaj and his team for some of my cases, particularly which are related with the bone. So when they were not uniting, when you have a lot of problems, so then I came across these things and was really fascinated about the results. So then on, this is my actually a passion where I just generally take this across. So for me it's not just blood and bones. Of course I do some kind of, I may not be as molecular level as you guys are. Most of you are very molecular. The other day I heard Praveen speaking in our hospital. I think it was fantastic talk, Praveen. Yeah. So for us, I think as we all know, the medicine has done a wonderful job by increasing the age of a person. At the same time, we are aging, but our organs are not really catching up with that. So that is where I think our regenerative therapies or any of these kind of lasers, I'm not sure about the lasers, definitely these regenerative perspectives are coming into picture. One thing. And number two, thanks to all these difficult regulations by the government authorities, other things, to do a research onto a drug, also you need not have an animal model or such things for a testing in a trial. So from this perspective also I would think regenerative medicine or tissue engineering will be definitely beneficial. So I'm sure you must have seen this video of a newt, right? In many of the talks, where the limb regenerates. After you keep on cutting it, it regenerates back and again. And the deer antlers grow time and again. So why not a human limb also grow like this? Of course, that is what we would all love to have it, right? Definitely when you cut a limb, and you should have it nothing like it. And I think my job will be very less. See, my job in orthopedic oncology is to save limbs. That is, instead of amputating, we save the limb. That is limb salvage surgeries. Many times we will not be able to do them because of multiple reasons. So with the help of regenerative therapy, that is mesenchymal cells and good biological matrix, biomaterials, I think we should be able to achieve it at least in the near 15 to 20 years if I'm not so humble enough. So orthobiologics is what we say, which will help me in definitely healing the bone faster or healing the musculoskeletal tissues faster. So in these aspects, we have about three different components. One is pointer. Yeah. So the first is, we can consider it as three things. One is the matrix, which are held by the tissue engineering people. I'm sure you must be, many of you must be involved in the tissue engineering. That is development of different matrices. Let it be a bone, which is mainly into the collagen and collagenous structures, or even in an allografts. That's what is another component. Or growth factors like bone BMPs or platelet-rich plasmas. And the end is the stem cells, which are mesenchymal stem cells, which are of most important for me. So we use a lot of bone substitutes because when we remove a tumor, definitely we would require a lot of bone or bone substitutes to reconstruct. So in India or this part of Asia, I'm sure many of you are from across the world, many of you are from US, I see. So many of them, you have an allograft bone bank. So that is where your the defect of any bone tumor removal will be, filled up. Whereas in India or in this part of Asia, we do not have a very well maintained bone bank, thanks to a lot of difficult authorities and regulatory bodies which are putting the bones into the Organ Transplant Act and etc. etc. But so what next? So what I do generally is we import the allograft. Say a humerus, what you're seeing there on the right corner, it'll cost you about 2.5-3 lakhs for me just to get it from Italy to here, which is actually would not cost so much. Actually, in India, with a billion plus population, I think we should be having it in tons of it, or rather loads of it. And with but thing is, because of this, not many people in the government authorities want to understand to that level, so that I can convince them and get it that there. So we are developing an allograft bank, which is definitely a cost effective for us in our country, like we are developing, and also it's very biological. Biological is the word I would like to use, because many a times, I think you all know, what is the treatment of osteoarthritis? Anyone? NSAIDs followed by replacements. So just take it off, remove it. So nobody is even thinking of healing it, right? So that is where I think we should all, grow in the future, what we call as orthobiologics, or healing it. So that is how even I, and even Professor Marco Manfrini was my mentor in Italy. He also believes biological reconstructions are the best for any reconstructions. Like when you remove a shoulder like that, that bone is replanted to a boy, and he will have a normal function, almost normal function, which a metal prosthesis cannot. So that is what we are aiming at, and getting the tissue engineering and the biological substitutes to that. And there are a lot of commercially available products like tricalcium phosphate, calcium sulfate, and coralline hydroxyapatite. With my experience, none of them really do that good job as a bone, a normal human biological bone. I'm sure they have published a lot of studies telling they are good, one fellow is better than the other one, but no. And the next one is the growth factors, BMP, I think bone morphogenic protein. They have put a full stop or a comma, I would say, in its usage, because as nobody knows how to stop the growth of a BMP's action. So for me, the easiest one and the more economical is platelet-rich plasma. We have a lot of experience in platelet-rich plasma. I'm sure you all know what is platelet-rich plasma. So it is the platelet buffy coat, which we take it out from blood and activate the platelets and degranulate them for its beneficial effects of interleukins and other growth factors. So we use it for multiple reasons, and we use a double centrifuge method. From Dr. Gururaj is here. It's from International Stem Cell Divisions, which is closely associated with HCG. So I don't really go into the nitty-gritty of how they prepare it, but definitely the platelet-rich plasma is being used. These are the factors which are present in the granules, dense granules, alpha granules, and chemokines, which help me in definitely healing of any of these tissues. So this is one of our first case we use for the non-union of a osteosarcoma of the proximal tibia, which we had used for reconstruction in the, if you see the lower part, there is actually a non-union which got united. So this is how we injected. Don't know. Anyway. I think the videos are not playing. You have a fantastic screen, but interface is not good. Yeah. Yeah. These are few cases which we have used our platelet-rich plasma in multiple conditions. Many of them are either my relatives or my friends or my hospital mates. So I think we all experiment well with our relatives and ourselves more than the patients. Definitely, I think it is done really well. Maybe first initially I used to think it was biased, but no. Definitely it is doing a fantastic job, evidenced by, I think all these people have traveled across the world to get a PRP shot done, if I'm not wrong. So this is the evidence for that. In the initial, I think this was in 2014, when we did an MRI. Yeah, if you see this MRI, see this is, she is a runner, and she had a constant pain for say about 6 months to 8 months, which was treated by NSAIDs and everything, rest, stop running, do only yoga, do other exercises, but she was hell-bent on running. So we gave a platelet-rich plasma. This is what you see after say about, this MRI is about 1 year later, 1.5 years later, but definitely you can see this is the edematous lesion which was there, and it's classically it's evidenced here by its absence of the uptake, absence of the edema. So that means definitely there is a healing power which is helping us out. That is just the PRP. There is no mesenchymal cells given in this. So again another video. I think we'll skip that. Yep. Yeah. This is another lady who is a trekker, who treks a lot of hills around. So if you see this on the left side, you have pointer work agala. Yeah. Nope. Yeah. If you see this on the left side, the tendon Achilles. Sorry. I'm sure so it went off somewhere. Anyway. So that also had a very good tendon Achilles repair. So just excuse me, I'll just rectify this. Yeah, that is our experience. I think it's somehow the slides are also getting missed. It's unusual. Yeah. Yep. See, if you see the tendon Achilles, I'm sure you can make out where the tendon Achilles is. It is wavy. The collagen looks very wavy. If you see on the right side, it is very well organized collagen on the tendon Achilles area. That is what the MRI signals also shows, that the tendinosis part is completely healed and she is back to normal activities. So so we have an experience of about in 55 conditions, about 166 injections in over 40 patients. Visual analog score and WOMAC scores have really showed us there's a definite benefit. This is just PRP alone. We have cases where we have mixed PRP with Synvisc, that is hyaluronic supplements, and stem cells as well. So some patients that we need to analyze them. Probably next time when we meet again, we shall have those results out. So that is our work with the platelet-rich plasma. I think across the world, I'm sure you must be knowing Google has invested a huge amount of money in regenerative medicine. Calico is a company, I think, if I'm not wrong. I think they have got this worm double his age by C. elegans is the worm. I think Cynthia Cannon is the one who has done a lot of work on this. So when you see this worm, I'm sure at least you can see this video. Yeah, that's the worm. That's the C. elegans. So they have changed the DAF2 mutation. They have done a DAF2 mutation. This is the long-lived mutant worm. It is a normal worm. That means it is not mutated. So after, say, in 13 days, I think we should start crying, of course, it starts dying. So that is what it is, almost like it's a very little movement there. You can see a small movement. It's in 13 days it's almost dead. Whereas the DAF2 mutated worm, this is almost dead. Yeah. If you see this 13-day-old adults, it is still running around the same age. So they have effectively managed to double the age of this worm. So considering the same concept, I think the Larry Page and others wants to double their ages as well. Probably they are heading towards that. So in mesenchymal stem cells, we have experience of about 25 cases in various conditions of spinal cord injuries, osteoarthritis, and some avascular necrosis of the hip joints, which is literally where our results are having, I would say, a mixed response, and various scores have been tabulated for each cases. Like spinal cord has got a different injuries, so we do not have so much of a case load or a database for me to tabulate them and present it in front of you. So our results with mesenchymal stem cells have been mixed, but definitely they are doing very well with the osteoarthritis and some cases of avascular necrosis. So with tissue engineering and definitely we're going to add with the stem cells, we will have a good biological, that's our aim, to have a good biological substitute for a replacement in orthopedic oncology forming. So that is how I think we should look it in forward, with the help of mesenchymal stem cells and a good tissue engineering and with good growth factor support. I think we can the clinicians can at least have a good support from the scientists like you, and thank you for your attention. Was it very confusing or probably? I'm sure I'm a clinician.
This mesenchymal stem cells, you are using the mono cells, or you are further characterizing them into CD19?
I think Dr. Gururaj, I think you should answer that. Gururaj is there. I think depending upon the conditions, ma'am. For example, if it's in the joint, requirement of a joint area, that is intra-articular injections, we use a different cell line, and if it's a avascular necrosis, we use a different cell line. That's right, Gururaj?
Yeah, it depends on the situation, but for most of your cases, we are using cultured mesenchymal stem cells. Expanded.
Which passage? With
bone marrow, we work with less than passage 5. It depends. Most of the work is done with bone marrow stem cells. Autologous.
Autologous, yeah.
Bad, as in,
Yeah.
Okay, they don't purify, and in the stroke fractions only 1% constitute the mesenchymal stem population. So that is why I was wondering whether you are giving, that means up populating the 1% to passage and then giving them?
It depends. The literature suggests that you can use total bone marrow stem cells, which is a mononuclear fraction, because it also contains the endothelial progenitors in it. But we also work with either expanded mesenchymal stem cells, which are pure mesenchymal fractions, or we work with mononuclear fractions, which contain all the 3 different fractions, including mononuclear, endothelial, and mesenchymal.
Because experience with mesenchymal stem cells has been very mixed, especially with respect to their stability. Because if you go beyond 5th passage or 6th passage, you know, the mesenchymal cells don't expand. They don't expand beyond 5th passage.
Which mesenchymal is this?
Including the bone marrow, and umbilical mesenchymal stem cells, what we have harvested. Go only max 10 passages, and then we go for a cryopreservation. Because after that they show apoptotic like this. We can go beyond that.
We can talk offline on this. We have a DBT project which was done on cord mesenchymal cells characterization. We have seen for passage 18, we have seen good response, and they don't senesce. So, but we can talk about it later.
Great talk. In terms of timing of PRP, do you find that you need to go in multiple times, or obviously we expect that there will be a patient variance, but what is your experience with multiple treatments? Is that something that works really well?
There is no standard line of treatment for every individual case. I think this is where we are going toward personalized medicine. So what I would suggest, what I would see if in the future is, we know that PRP works. Probably depending upon the extent of the injury, say about a chondral injury in an athlete, probably would not take more than 2 or 3 shots of PRP. Whereas the same injury in an older age, maybe it's an osteoarthritic injury, probably she would require a PRP along with the stem cells and a Synvisc. I think that is where the clinicians have to titrate and probably decide with the help of you. I remember the last slide of yours yesterday. I think without that, yeah.
Thanks.
Yeah.
How about following up the homing of the cells?
Sorry, ma'am, I didn't get you.
Homing. Homing.
Homing. No, I have not studied on the homing on the cells.
Because you said for require less amount.
Athletics. Yeah.
It is because of the
no.
Nice talk. So one of the things in the world and stem cells that they realized is that upon transplantation and even expansion of the cells, there's a person expand, but on transplantation, there's a high percentage, and I was wondering, said, for example, you get out in 5 years, whether that was really due to the percentage that could be as high as 80% in some cases. And there is some indication in literature after transplantation increases the survival. Experts here in stem cell have considered the amount of cell
in place for longer duration. So that is a challenge. We 8 years back, when used to be and the period for gel stay there for, but nobody how need such a dynamic organ. I mean, we do not know whether it's going to stay or not. And later I saw with Professor in is Mayo region, where he says with that biomaterial, it is like a gel foam. Have you seen gel foam? It is like a sponge. So he just loads it and sticks it into the defect. And nobody knows how it's going to stay, or that's the difficult part of it. I think that is the challenge, and it becomes more and more morbid. The procedure becomes morbid. Opening up a knee joint, you're causing more problems of stiffness, infection, and you are talking about a therapy which is still not into vogue. If it's into vogue, then okay, they will agree. The patients would agree. But if you're telling, okay, we can try this, means they would not like to have more morbidity. So nowadays, mainly we do intra-arterial injection, safe and simple. But as you rightly put, there will be cell loss, definitely, and the concentration of cell loss is a challenge.
Thank you. Thank you, sir.
Thank you very much.
For nice presentation.
Thanks.
Please, sir. Hello. Yes, sir, please.
Oh, hi.
Yeah. Sir, in the chronic tendinopathies, just like chronic tendinopathies.
How many?
Chronic tendinopathy.
Chronic tendinopathy.
Just like tendinosis and the tennis elbow.
Yes.
It is usually found out that tendinopathy is caused by the positional faults of the tendons. There is some biomechanical dearrangement in the tracks of the tendons, which causes the tendinopathies. If we only judge to the PRPs, as you suggest the PRPs, is it helpful for the chronic tendinopathies? Only the PRP will helpful to improve the cases? Because there is some biomechanical disarrangement of the tendons tract, which is responsible to cause the injuries to the tendons.
Yeah, that's a fantastic question. Because thing is, as you rightly put, say for example chondromalacia patella.
Yeah.
So chondromalacia patella, what happens? The patella glides onto the outerwards, right? Due to various reasons.
Yes.
It could be because of post-pregnancy, it could be because of a wrong running, runner's knee, so because of wrong exercises. Unless you correct that biomechanically, mechanical things, this will not work. This may work temporarily. For permanently, you need to correct the mechanical problem.
Yes.
Yeah, you need to assess. That's what. It is not like one person, one single shot of a stem cell or this one. It has to be holistic approach with the help of clinician and everybody. Absolutely right
because
point.
In Achilles tendinitis, that will be the navicular drop and the calcaneal inversion that will cause the factors in the tendinosis.
Absolutely.
So, thank you.
That's correct. Sure. Thanks. Thanks a lot.
That was a good, nice presentation by Dr. Pramod Chinder. And we are having the next speaker, Mr. Michael Weber. And after Mr. Michael Weber's session is when we break for lunch. However, let me introduce Dr. Michael Weber, who started his career in chemistry and biochemistry in Germany, and also started his first laser clinic in 2001. Later, he has even spread out of Germany into Thailand, and now hopes to spread his laser clinics in many other parts of the world. Dr. Weber specializes in regenerative medicine and photodynamic laser therapy of cancers. So let me request Dr. Weber to come in on stage. Thank you.
Yeah, you can click this one.
working? No, it seems to work. No, no videos. No, no. This is working? Yeah, no? Okay. 1 second. Okay. Thank you very much for your nice introduction, and I would like to thank especially Dr. Murphy for inviting me to this first conference in India. So I'm here the first time. I flew many times over India from Dubai to Bangkok. I have a clinic there, he told already. I never wanted to go here in this country because it's a huge country, of course, and I know that Indian doctors are very interested in natural therapy, even in homeopathy. And I met a lot of good doctors, and you have a very, very good medicine. It's well known in the world. So I'm very happy that I can present you a little bit about our new methods, what we developed in laser therapy. We are working on this field already more than nearly 20 years, and we tried to bring laser therapy nearly in all fields of medicine. Because light is life. Everybody knows this. We are all made from light, from the sunlight. And everybody knows we cannot live without the sunlight, and we need the sunlight for our life, but also we can use the sunlight for healing effects everywhere in the tissue. And we heard already something about stem cells this morning, about PRP, how we can use it and how it works. But we can enhance all the effects using laser therapy. So in this lecture I want to give you a short overview about all the fields of laser therapy, where we can use it, how we can use it, in which diseases is interesting and successful. We have some more lectures in the next days where I will give you some more special data, but I would like to try to give you a short overview. So in the first slide you can see already, working or not? Yeah, you can see already that we are using lasers for external applications. Here you can see maybe for so-called laser needle acupuncture. These are non-invasive therapies, but the problem is if we want to use light in the body, it's sometimes difficult. We know that from outside red or infrared laser can penetrate the skin, and we can get some effects maybe in 3 up to 5 centimeters of the body. But one of our best lasers what we have today, which is cooling down inflammation, is the blue laser. And the blue laser doesn't even penetrate 1 millimeter into the body. So the problem is, how can we bring all the lasers in the body where we want to need them? You see on this picture we also use intra-articular laser. We heard already in the first lecture now that PRP is used for regenerative effect in the knee, but we can enhance the effect of PRP. Or maybe injected stem cells, they also need energy for differentiating using laser therapy, and we can bring it directly in the knee joints. Another method is using the light in joints, for example, or intravenously in the bloodstream. So in this method you see we can bring now all lasers into the bloodstream for achieving different effects. So speak some words about basics of laser light: non-invasive, invasive laser therapy, external, interstitial, intra-articular laser therapy for pain management, intravenous laser for energizing and chronic diseases, combination of lasers with PRP and stem cells, and regenerative laser therapy in dermatology, and some new data about photodynamic therapy of cancers. Laser is an amplified strong light. We know this. And everybody, if you tell your patients about laser light, laser is dangerous, laser is strong, and if you bring this in the body, you will destroy something. No, we are just doing the opposite. It's dose dependent. You know this. We use low power laser light and have just the regenerative effect. We can describe lasers in a dualism. Lasers can be described as electromagnetic waves or as particles, and then we call them photons. A laser normally is produced in a laser medium. This can be a gas maybe, or a semiconductor substance. We stimulate mostly with electricity. Photons going up on a higher level, they fall down, and we produce billions of photons. They run between 2 different mirrors, and then we get a so-called standing wave coming out as a laser beam, maybe a red laser, green or blue or yellow or any other color. Laser light is monochromatic, has only one wavelength, and laser light has a specific order, what we call coherency, in contrast to light coming from the sun or from the ceiling here, which is a mixture of the different wavelengths. We have to know something about the wavelength. We can use frequencies, so we can use pulse lasers. We have something to know about power, watt, milliwatt. Energy is power times time, and also the so-called output intensity. So we will not speak about the surgical lasers, what we also use in our clinics for destruction and coagulation. We use low power lasers, maybe to improve wound healing, or maybe to improve the microcirculation for quicker healing of a chronic wound, maybe in diabetes. Yeah, so the normal light is a mixture, you all know this, of all the spectral colors, the blue, the green, the yellow, and the red one. You know this from the rainbow. So the shortest wavelength is the blue, then comes the green, then the yellow, and the red one. What we cannot see, what also is in the sunlight, is the ultraviolet light and the infrared light. Very important to know, the shorter the wavelength is, the more energy the light has. Yeah, if we have very short wavelengths, maybe gamma rays or X-rays, they have a lot of energy, they can lead to mutations in the cells. The visible spectrum of light is a very small area here between 400 and 700 nanometers. This light is normally not regarded as dangerous. Also the near infrared light, which has a lower power of energy. So today we are using different lasers. We have different blue lasers, green, yellow, red ones, infrared. Everything is available. I brought everything, all these devices with me, and if you want to see the different lasers, you can look later outside in the break. What is very important, what we did in our research and development, we put the laser in very thin fibers, maybe from glass fiber or plastics, so then we can increase the power per square centimeter a lot, and then we can bring the laser light deeper into the body, or maybe using some special catheters in the bloodstream or even in joints. Because the problem of laser therapy still is the skin. The skin is made from the nature to protect us against too much light. So how can we bring the lasers through the skin? Because there are so many disturbing effects below the skin, refraction, scattering, non-specific absorption, and maybe we want to treat a damaged area in the depth of the tissue. How can we bring all the colors there? It's very difficult from outside. You see the penetration depth of light from outside. Blue is very low. Green and yellow a little bit better. The red is better, and the best one is the infrared. And the far infrared, when we are going to higher wavelengths, we have a lot of water absorption and again low penetration. Here you see the absorption of light in the chlorophyll. We need the chloroplast because we cannot use the light directly as humans. That's our problem. If we would have chloroplast, we would be green people, and then we could pick up the light ourselves, but it's not possible. We need something in between who picks up the sunlight and makes something how we can use this sunlight. And the chlorophyll, the absorption spectrum of chlorophyll is blue and red. The green light is reflected, goes in our eyes, and we think the plants are green. We have something similar. We have no chloroplast, but we have mitochondria. And in the mitochondria, which are also developed in the sunlight, we use what is produced in the chloroplast, the oxygen and the carbohydrates. So if we look a little bit in detail on the inner membrane of the mitochondria, we have the NADH, you see what is coming out of the citrate cycle, and then the NADH is oxidized on the inner membrane of the mitochondria. At the end, we produce the ATP. So how is this working? The NADH gives the electrons to the first complex, to the next one, and this energy is used to bring protons out of the other side of the membrane. We get a gradient, this will break down and delivers the energy for production of ATP. Why are you telling you this? If we look in detail on the different complexes, they are all chromophores. They are developed in the sunlight, so we can stimulate this one with blue light, the second one, the cytochrome complex, with blue and yellow and green light, and the cytochrome C oxidase, the last one, with red and infrared light. You see, that's the secret. We speak about regenerative medicine. Regenerative medicine means we have to regenerate the cells and the tissue. Yeah, we can do it with help of stem cells and PRP, but we need the light to stimulate the mitochondria. And then we have a signaling, a second signaling. This is a picture from the famous Tina Carew, then using here different intermediate substances like NF-kappa B or cyclo-AMP to give the stimulus on the nucleus for dividing of new cells and tissue. So that's a little bit excursion in the field of biochemistry. So first of all, we have to distinguish between non-invasive and invasive laser therapies. For non-invasive therapies, we have set up a fiber optic system using up to 12 different lasers, which we then call laser needles. But these needles are not inserted, they're only attached to the skin, and we can use all the spectral colors. And these fibers have only diameter of 0.4 millimeters. So there's a very, very high concentration. And if you look at the applicator diameter and the watt per square centimeter, we are using only 0.4. So the power per square centimeter in laser needles is going up to 50, sometimes up to 100 watt, not milliwatt per square centimeter, but we will not damage anything on the skin. So I show you some practical things, what we are doing. You can connect them to the skin. We use them for trigger points, for acupuncture points. It's a very nice treatment. It's very, very famous now all over the world. There's an approval in the US, from the US FDA. We have some thousands of doctors using this successfully, mainly red and infrared lasers for the different treatments from outside. I published with my group in 2007 already a study in the Medical Acupuncture Journal in America showing a long-lasting effect of laser needle acupuncture in knee osteoarthritis, low back pain, shoulder and migraine. Peter Dorscher is here. He's one of the most famous researchers in acupuncture and is head of the Department of Pain and Acupuncture in the Mayo Clinic in Jacksonville. And I think he will present some more data about this because he was the one who compared first time the effect of laser needles to the normal metal needles, and the effect of the lasers were better. Why? Because besides of the acupuncture effect, we have regenerative effects. We can put lasers in showers to make it easier and then put the shower heads maybe on joints. Very interesting is transcranial laser therapy. We know that especially infrared laser can well penetrate the brain, so we use it today in degenerative diseases of the brain, like Alzheimer's or Parkinson. You see here the infrared lasers on the brain, because infrared laser can penetrate the bones very well, in contrast to the red laser. Professor Litscher in Graz University, he made more than 800 double-blind placebo-controlled studies with laser needles. So many studies with amazing effect, and now they are working on a brain model. You see the skull model and checking different lasers. And he published last year the penetration of lasers into the brain. The best one was still the infrared. Even red and yellow to a certain amount can also penetrate the brain. How can we do invasive laser treatments? According to old Russian research, we are setting up sterile catheters connected to all the laser models, and now we are able to bring red laser, blue laser, green and yellow laser right into the bloodstream. We also are able now to bring a blue laser, and I told you before, which has a wonderful effect, but cannot even penetrate. We can use fiber optic needles to go close to a damaged nerve or damaged spine or even in a joint and bring such lasers which have very good anti-inflammatory effect right into a joint or maybe into the bloodstream. Also, we are using today those lasers for stimulation of photosensitizers in different cancers, for example, this lady with a breast cancer. So there was a very nice study. We have seen already some data in the lecture before from Frankfurt University, using only showerhead with red infrared lasers on damaged osteonecrosis of the knee, and after 2 months, complete healing of osteonecrosis, not arthritis. So if we want to bring now the lasers better into the body, maybe for a damaged, herniated disc or something, or other problems of the spine, not like the orthopedic doctors, they inject the steroids, of course, but we do not want this. Steroids will not heal the tissue, they will destroy the tissue at the end. So we are using the same technology, but when the needle is here in place, we inject some saline solution, then we have like a water bubble, and then we can put in every laser, blue and yellow and green and red and infrared, for achieving healing effect on the spine. This is a typical spinal needle with an inserted catheter where the laser is coming out at the end. So this is, for example, a treatment on the spine. You see this patient had already a scar here. Also we inject the PRP and also sometimes the stem cells. Osteoarthritis of the knee, huge problem. Millions of people worldwide. And we use spinal needles or maybe even plastic needles to put them right into a joint, and this joint is irradiated from inside. This light coming back from inside, and if you inject the stem cells and maybe PRP, you can activate all this, and the effects are amazing. Damaged shoulder, very big problem, even with acupuncture, difficult to treat. So that's another option to put needles in the shoulder, and for anti-inflammatory effect, and it's like in Chinese medicine, you know, the blue laser is cooling down like the water, like the sea. The green laser is like the nature, you know, that brings more oxygen in the blood. The yellow stabilizes the middle of the body, so has very good anti-inflammatory effect and antidepressive effect, and the red laser pushed everything. If there's acute inflammation, we would never use a red laser. Yellow mostly and blue first. You see we are using 2 points on the shoulder invasively, or maybe on small joints. Blue laser works the best. So the laser can be applied in the depth of the tissue close to the spot of injury. One or more interstitial needles can be added to superficially applied laser needles. Pain relief is better. It's like a combination of a metal needle with the inserted fiber optics. Very important in people with dark skin. How can you treat in black people in America a herniated disc from outside? Is impossible. You are only heating up the skin. And blue and green lasers can be applied as well, and better effect on tissue regeneration. Yeah, we heard this already. We also combine very well with PRP, what we take from the peripheral blood. You see, you had heard already, you have seen similar pictures already. We get the Buffy coat with the platelet plasma containing the anti-inflammatory cytokines and a lot of different growth factors, and the interleukin-1 receptor antagonist, which works against the bad interleukin-1, which leads to cartilage damage. And we use it for wound healing, tendinopathy, fractures. We heard already something about this. Even stem cells, you know, we can take them from bone marrow, we can take them from adipose-derived tissue, and then we stimulate the stem cells with light. You can do it maybe before you inject them. Some people put the stem cells in a device with different LEDs, and then they inject it. We do it in a different way. We inject them in the joints, and then we make the interstitial intra-articular stimulation of the stem cells. Now we also with intravenous stem cells. We inject the intravenous stem cells. We can stimulate them by intravenous laser therapy. We can target them maybe using ultrasound shock waves. Yeah? Then you can better target them to the organs where you want to have them to work, maybe on the spine or on different joints. And then, of course, we try that they will differentiate into different organ cells, maybe on the brain or anywhere else. So you see, we are using everywhere the laser. There is nearly no disease what we cannot treat even additionally with laser therapy. You can use it in old skin, of course. Arthritis, brain diseases, COPD, diabetes, we heard already, erectile dysfunction, heart failure works very well. Yeah, and mostly we use fat, sometimes bone marrow, so the most of the stem cells are in the fatty tissue, although there is a lot of discussion about this, I heard already. And so this is a typical liposuction, small liposuction for getting the fat, and then you can use it for intra-articular injection, interstitial injection, intravenous infusion, followed by laser therapy with all spectral colors to give the mitochondria of the stem cell enough energy so that they will grow and will differentiate in organ cells. You can use it for hip joint arthritis, for knees, we have seen this already, skin rejuvenation. Yeah, and I think you know this man, that's me, you know. Treated myself with some fat and some, I did it in front of the mirror, you know, and then injected and gave me laser therapy. And this is before and this is one day after. Yeah, so you see it works. This lady before and after works very well. Yeah, intravenous laser therapy, some words we speak more in detail later. We can put a catheter right into a vein. We use the different colors today. We have the full spectrum now. The red laser shining through the skin. This is a 12-channel devices using all different colors. We stimulate the mitochondria, an old picture from Tina Carew. We stimulate ATP production, you see here with the red laser. We even can stimulate, oh, I have to go back. Yeah. We use it for heart failure, for example. Even the intravenous laser, you know, why is the intravenous laser working well? At the end, we stimulate our own stem cells, which are released out of the bone marrow all the time, yeah, in our circulation. And once they get the laser therapy, they maybe will go to a place of chronic infection and degeneration, damaged liver, damaged kidney, damaged heart, and then we see at the end that maybe ejection fraction is better and also heart function is getting better. So there's strong evidence that regenerative effects of intravenous laser therapy are induced by stimulation of the body's own stem cells released from the bone marrow in the bloodstream. Yeah, that's something what I want to show you. We never have time, even me, we never have time to treat ourselves. We're always running around. I'm working 14, 16 hours every day treating my patients. I never have time to do something for myself. I fly to America next week, to Asia, then I have a lot of patients. That's the only thing what I can do. This is a so wonderful development. We have some outside and you should try it in the break. This is a laser watch which has 10 lasers on the backside. It irradiates in your arteries, radialis and ulnaris. Even there are acupuncture points of the lung, heart and pericard meridian, so your blood pressure will go down. You see, that's the acupuncture points. What you can do yourself. I wear it every day, morning and evening, 1 hour, and works against inflammation, opens up the microcirculation, stimulates the mitochondria. It works similar like intravenous laser blood therapy. We made a study showing that melatonin is going up 100%. Serotonin is going up. It's the same metabolic pathway and has so nice effect. And that's me in the A380 on the way from Bangkok to Germany, so I can jump out of the airplane and can work, and I'm not tired nor jet lag anymore. Nitsche made new studies showing that the heart rate variability is improved and also the microcirculation. So we have a lot of good studies running now in America. With the US Air Force, we have a study running in the moment showing blood pressure is going down, so you can remove some of the medication. I have seen good results already in diabetes. We had a Swiss study presented on our international conference in June showing that cholesterol was going down and blood pressure, so that's a very, very promising result. And we can protect ourselves a little bit. Using maybe some curcumin additionally and some liquid chlorophyllene, this protects us maybe a little bit even against cancer. So, some last slides, photodynamic therapy. This is our main field now. We use different photosensitizers which we inject in the body. They will accumulate in tumors, and then we irradiate with the right lasers to stimulate them and destroy cancer cells. Yeah, if this is a breast cancer, we can stimulate when the photosensitizer is bound to the cancer cells or inside the cancer cells. However, the problems remain. How can we bring enough laser light deeply into the body? Yeah, we want to break down the cancer cells with the photosensitizer and produce reactive oxygen species by light to break the cells down and then induce all the immunological pathways, activation of macrophage, dendritic cells, cancer antigens. That's the way of photodynamic therapy. We have chlorophyll-derived photosensitizers like chlorine E6. The best one today is liposomal indocyanine green. Also we use plant photosensitizers from St. John's wort. This hypericin curcumin. Aminolevulinic acid is something as a cream. We use it for healing of basallioma, for example. Many of them are chlorophyll or hematoporphyrin derived like chlorine E6. This will be injected. After injection, we treat the blood for removal of circulating tumor cells, and then at the end we can treat by laser irradiation. If it's superficial, we can do it with a shower, but if it's deeper inside, we use again the interstitial technology. Here, a patient with malignant melanoma, we put the lasers right on the tumors or thyroid cancers. Very good case here with breast cancer with chlorine E6. So another patient here from San Francisco that treated with big breast cancer. And the newest one, and this is, I think, the future of cancer therapy, is indocyanine green, an approved drug. This is the first photosensitizer which works with infrared light. And infrared light goes through the bones. So now we can treat bone cancer, bone metastasis, and even brain cancer. Normal indocyanine green, however, leaves the body very quickly. We have to use it. This is the indocyanine green. You see the absorption spectrum, infrared light. And a new option is now put it in nanoparticles, yeah, like liposomes, yeah, and then it will go into the tumor cell, but it takes some days, 3, 4, 5 days, and stays nearly 2 weeks in the tumor cells, and then we can irradiate with infrared light. We get a photodynamic effect with reactive oxygen species, and also something like an overheating effect. And the results what we have now are really amazing. Pancreatic cancer, you see the green substance. We make all the endoscopies. You see the fiber optics here in the colon, and you see the colon nodes here from the colon cancer. And the next day, here the fluorescence, after switching on the laser, you see the cancer melting away overnight. No? So bladder cancer, prostate cancer, it works very well. We have a big group now in Germany, in different other countries working on this field. You see, this is a typical treatment. We put the catheter right into the bladder or maybe inside the prostate. It's non-invasive with amazing results. And yeah, that's my last friend. You want to say thank you very much for your attention. And in the next days, I will tell you a little bit more in detail. Thank you very much. So we have a booth outside. You know, all the different lasers are there. And if somebody wants to get a treatment, intravenous laser or something, somebody has pain, we have a small room there. So if you want something or you have a bad knee and you want an intra-articular laser, we can do everything here. So you are invited anytime to join us.
It's a wonderful talk and very informative. I just have one question. So you were saying that when you are giving interstitial applications of approach, it is the bone marrow which is trying to, release the stem cells. Or is it probably that the target tissue itself, the resident stem cells are getting activated?
Yeah, I think we have to stimulate the target tissue. So if we take the stem cells maybe and we give them in the joints, or maybe even intravenously, after cleaning and washing procedures. I think it's very important to treat the targeted tissue maybe over several weeks to keep the stem cells alive, that they will divide in new cells, after homing. For homing, mostly now we use ultrasound shock waves, which works very well. Even maybe with laser therapy. If we maybe inject stem cells intravenously and want to treat maybe brain diseases, some will go through, some will stuck in the lung, of course, But then we work with intravenous and transcranial laser. And for example, I've treated a young girl with 20 years with hereditary cerebellar ataxia. You could even walk and not swallow anymore. And we treated the whole family is affected there. And after 2 or 3 treatments, she could swallow again, she could hold her leg up. I think this has a huge option for the future. This, with the stem cells and everything intravenous, we started maybe some months ago. But I think it's a huge treat. And I heard your lecture about your diabetes. It's so amazing, And that's one of my big hopes, that with laser therapy, maybe we can go close to the pancreas using the interstitial technology, then improve your...
Especially for the type 1 diabetes, where you can really say the juvenile, the younger population. It's going to be. I have just one more question. Your data on the serotonin levels, where you also showed that you had a very deep sleep with the laser watch, it was very interesting. How do you think that it is able to have an impact on the, the serotonin metabolism? I mean, at the biochemistry level.
The laser watch is an amazing product, because I told you already that stem cells are released all the time from the bone marrow, and if we use this on a regular basis, we can even stimulate our own stem cells. We improve the microcirculation. We know this from old research. And we are not treating intravenously, we push it in the artery, of course, which has much better blood flow. And, I have some first diabetic patients, type 2, not type 1, and I have seen, starting with the HbA1c with 10.5 or something, going down to 7 now. We have seen in the Swiss study that the damaged liver the liver values are going a lot better. The heart function is improved. I think this has a huge option, because this is something what patients can do at home additionally to support our therapy, and what you can try yourself.
Yes, we
have the watches outside. If you want to have one and use it maybe for 1 hour, you can borrow one. Try yourself.
Try. Thank you.
Okay, thank you. Okay, thank you very much again.
Sorry, just one quick question.
Yeah.
Have you seen any side effects or any contraindications or anything while you have treated with so many different varieties of lasers?
Once more, I did not understand correctly.
No. Have you ever had conditions which have inflamed further or got worse while you were treating? Are there any side effects that you have seen?
Yeah, this project everything is quite new. No? I think we will have good effect also on angiopathies, because we know from all this old research the viscosity of the blood is better. I think this is a huge protection against cardiovascular diseases, because still most of the people die from cardiovascular diseases, especially the diabetics with all these cardiovascular complications. Maybe we cannot remove the diabetes, of course. Of course, we can give them insulin, but we can prevent the complications from which people die later. No? But everything is quite new, and we made this project with this watch we have this 6-7 months. So maybe next year we can present a lot of more data. And anyway, we have the ISLA, the International Society of Medical Laser Applications. We are organizing international conferences in the second weekend of June. This year was already the 11th, and I always will bring the best speakers on the world, and I hope I can pick up some more speakers for next year on this conference. Thank you. Anyway, if there are more specific questions, I'm outside in the break. Okay. Okay, this presentation was okay. Thank you, Michael.
That was a nice eye-opener, Michael. And thank you for the nice presentation. We now break for lunch, and we assemble back here by 2:45. We'll be starting the session sharp at 3. A lot of our speakers will be available outside, and everybody should be able to interact with them on a one-on-one basis during this large lunch break that we have. Thank you. Enjoy your lunch. Thank you very much.